Welcome back to part B of Learning Plan 5, the cardiovascular and renal system. We're now going to be talking about high blood pressure. Excuse me. High blood pressure or hypertension. What is it? Well, there's two types of high blood pressure. Essential or idiopathic and secondary. What are the differences? Well, first off, sorry about that. Hold on. I need to. First off, high blood pressure is high blood pressure regardless of the cause. If a person has very high blood pressure, it doesn't really matter if it's idiopathic or secondary. It needs to come down. But sometimes how you treat it is based on the cause. That's why you need to kind of know. It's the most common cardiovascular disease and usually has no symptoms until you start having secondary events from it. Mild high blood pressure can usually be controlled, or often be controlled, by lifestyle modifications. The biggest ones: dietary changes, increased exercise, weight loss, reduced alcohol consumption, reduced salt consumption, reduced intake of saturated fat and cholesterol, stop all tobacco products, and find ways of controlling stress. So if you have mild hypertension, if you make those changes, frequently you'll bring it back down to normal. If you have very high blood pressure, you still have to do those changes to help, but you may need medications on top of it then. Probably the most important ones there is the diet, the weight loss, exercise, stopping tobacco. Some people are not affected by salt like others, but most people are. And I am. I'm definitely affected by salt intake. If I have a high salt meal, I can't take my rings off because your body pulls water in or holds water to kind of dilute the salt in your system. So if you've ever gone to a Chinese buffet or gone to a movie and ate a bunch of popcorn, and then the next morning you gained a lot of weight, it wasn't from your diet, it wasn't from the food you ate, it was from the salt. Moderate to severe high blood pressure requires medication. So normal blood pressure levels are systolic. The top number is 100 to 130. And actually right now they're saying under 120 is better. Systolic, 60 to 80. And again, now they would rather have you under 70. Essential high blood pressure or idiopathic, no idea what's causing it. It just is. 90% of high blood pressure is idiopathic. How's that for frustrating? You have a disease and we have no idea why. 10% is secondary, or there's a known cause. Again, people that have a genetic risk for high blood pressure, they may just have high blood pressure. Secondary high blood pressure is due to a cause. And finding the cause tells you how to treat it. Chronic high blood pressure, long term, can cause renal damage and retinal damage, and is a major risk factor for both TIAs and CVAs, transient ischemic attacks or baby strokes, and cardiovascular accidents, which are major strokes. So here's just a chart showing the normal prehypertension, stage 1 and stage 2. And even in prehypertension, you want to start taking action. Prehypertension is the best place to implement lifestyle changes. So lose weight, exercise more, control your salt intake. Salt intake, the US RDA is for people under 51 and white Americans, 2,300 milligrams of salt a day. If you're over 51 or African American, they say under 1,500 milligrams of sodium a day. 2,300 milligrams of sodium a day is about 1/6 of a teaspoon of salt. Most Americans get about 5,000 milligrams a day. Way too much. And most Americans don't have a problem with that until they have a problem. So start looking at your dietary intake of sodium, and it's amazing how much is in your diet. We're going to do a little exploration in class, just as an example, to see how much sodium is in people's diet. If you get to stage 2, over 159 and over 100, that's serious. You need to take action. Now, if it's one time, let's say you're at Walgreens, Walmart, whatever, and you pop your arm in the machine and it checks your blood pressure, and if you get 160 over 110, don't freak out. If that's the only time you've ever had a high blood pressure reading, you don't know if that machine is calibrated. What were you doing at the time? Did you just have a fight with someone? Did you just take an exam in pharmacology? Did you just break a leg? There's a lot of things that can change that. But if every time you check it, it's always very elevated, you need to see a doctor. So what are some things that can affect high blood pressure? Well, race and gender, and men having the worst problem than women. African American having a bigger problem than white Americans. Inactivity, stress, obesity, tobacco, age, salt, alcohol. Those all can make you risk for high blood pressure. And those are all controllable. You can't control your race or gender. You can't control your genes. But the environmental effects, you can control every one of those. It's whether you choose to do it or not. That's the question. And some of those changes are not easy. I'm not going to kid you. Losing weight, not easy. And especially keeping it off. Quitting tobacco, not easy. Never done it, but I understand it's not hard. You can't control your age, but you can control your salt and alcohol intake. Those are all a matter of, are you willing to do what's necessary? So high blood pressure is all about blood volume, peripheral resistance, and cardiac output. The volume of your blood is about 5 liters of blood in each person. Now, obviously, a person who is, 4'11" and 100 pounds will have less blood than a person 6'3" and 300 pounds. But it's not much different. In an adult, it's about 5 liters. Diuretics decrease the water in the blood fluid. And high sodium diets may cause water to be retained. And like I said, may. Some people aren't as sensitive as others. And aldosterone is a hormone that will affect the water levels in your blood too. Peripheral resistance. Now, as blood goes high speed through the vascular system, it has puts force against the walls of the vessels. The friction in the arteries is called peripheral resistance, just like anything else. With vasoconstriction, the inside diameter becomes smaller and smaller, and it creates more resistance and higher pressure. If the lumen is vasodilated, it becomes larger, and the resistance is less. Remember we talked about lipids, and they form fatty plaques in there? What do you suppose that does to the resistance? Of course, it increases it. It adds friction because the blood can't go right past it. It would be like cooking on a nonstick, Teflon nonstick pan, but leaving yesterday's food caked on there. It loses the nonstick surface. So we want to make sure our blood vessels are nice and non-stick. Cardiac output is how much blood is pumped out of the heart every time your heart beats. The higher the cardiac output, the higher the pressure. Stroke volume is how much blood is pumped out of the ventricle in one contraction. Cardiac output is stroke volumes times rate. This is important to know. Cardiac output is stroke volume times rate. The higher the cardiac output, the more pressure in the system. So how can we change cardiac output? Slow the heart, reduce the pumping pressure, and also decrease the available blood. So we have 3 different types of medications we're talking about right there. The regulation of blood pressure is done primarily in the medulla oblongata, which is also called the vasomotor center. There are pressure receptors, or baroreceptors, in the aorta and the internal carotid arteries, which sense the amount of pressure within the large vessels and transmit this information to the vasomotor center. That creates hormones and other endogenous agents which affect blood pressure on a daily basis. So if a person has low blood pressure, if those vasoreceptors sense that, it's going to go to the brain, and the brain is going to tell the heart to do new things. Maybe pump faster, maybe pump out different hormones. But this slide right here, slide 22, the hypertension slide, this is critical to know, because understanding this will help you understand every one of the medications we're going to be talking about now. So what are some common hypertensive treatments? Well, diuretics to eliminate water, calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, adrenergic agents, and direct vasodilators. These all affect cardiac output in different ways. The goal of antihypertensive therapy is to reduce blood pressure and avoid long-term consequences, which are heart attacks and strokes. Management is completely individualized depending on the patient's risk factors, medical conditions, and the degree of blood pressure elevation. If your blood pressure is very high, you're probably going to have more medications. If it's borderline, you might have one or none. Most commonly, it's two antihypertensives at a time. The advantage is when you use two medications at once, you need less of each medication, which is, of course, less side effect risk, and then better patient compliance. It's difficult to take more than one pill sometimes, so many manufacturers combine drugs into a single pill or capsule. We're going to be talking about some of those combinations. So, which drug to choose? Here's another follow the evidence. So I want you to click on that and find out what you can learn about that. So we're going back to our little chart of the blood pressure classifications. And again, if you have blood pressure under 120 and under 180, you won't need any antihypertensive. Prehypertension, still no antihypertensive drug indicated, but you'll have to take antihypertensive lifestyle modifications. Stage 1, most commonly a simple thiazide diuretic. And the most common thiazide diuretic is hydrochlorothiazide, which is abbreviated HCTZ. HCTZ is hydrochlorothiazide. Stage 2, that's when you start talking about combination drugs. Although sometimes, even in stage 1, a physician will prescribe two drugs. For the reason I said before, you need less of each drug, so fewer side effects from each of those, yet better results. This slide shows the 5 common categories: diuretics, calcium channel, adrenergic blockers, vasodilators, and renin-angiotensin agents, and then the subtypes. So diuretics, there are potassium-sparing, loop diuretic, and thiazide. That's what we're going to finish this slide talking about. Diuretics. Diuretics reduce blood volume. You excrete water and electrolytes. So that is the first way of dropping blood pressure, is to just reduce the amount of blood that's being pumped. It causes fluid loss, which can lead to dehydration. Blood volume is changed from fluid. Let me try that one more time. Blood volume can be reduced by fluid loss through dehydration or diuretics. And also it's affected by fluid retention, aldosterone or ADH. These are the first class of drugs ever used to treat blood pressure in the 1950s. These are considered the first line of drugs. They produce the fewest adverse effects, and they are very effective at controlling mild to moderate hypertension. The 3 diuretics, they're loop diuretics, thiazide, and potassium sparing. Loop diuretics, the most common is called furosemide, brand name Lasix. And okay, well, we'll talk about Lasix in a moment. Thiazide diuretics, hydrochlorothiazide, or Diuril is the brand name, but it's almost always prescribed HCTZ. And potassium sparing, or spironolactone. Now, the big thing with spironolactone, or aldactone, is you do not lose potassium. Those other 2 drugs, you do lose potassium. And that can be very important. So this slide demonstrates how the kidney actually filters out and uses these medications. So I'm just going to kind of walk you through here. Blood enters the nephron. It filters through Bowman's capsule. Water and other small molecules readily pass through that capsule, enter the first section of the nephron, which is called the proximal tubule. Now, once it passes the proximal tubule, it enters the loop of Henle, and then the distal tubule. Now, the fibrate is emptied in common collecting ducts and then into larger and larger collecting portions called the kidney. Fluid leaving the ducts and entering the portion of the kidney is called urine. Some substances in the filtrate. Well, I said that wrong before. The filtrate is emptied in the common collecting ducts and then it becomes urine. Some substances in the filtrate pass across the walls of the nephron to enter the blood. This is called reabsorption. So it leaves the blood and then goes back in. The most common molecule that is reabsorbed is water. For every 47 gallons of water that go through the through the tubules, 45.5 gallons are reabsorbed. Only 1.5 liters is excreted in the urine. Glucose, sodium, chloride, and calcium are also reabsorbed. Certain molecules are just too large to pass through Bowman's capsule and may enter the urine by crossing from the blood to the filtrate in a process called secretion. Potassium, phosphate, and hydrogen enter the filtrate through this mechanism. Reabsorption and secretion are critical to the pharmacokinetics of many drugs. Some drugs are reabsorbed while others are secreted. Heart failure. Heart failure is the heart is unable to pump blood sufficient from the ventricles to meet the body's metabolic needs. So the ventricles just can't pump. The amount of blood pumped by each ventricle is called the cardiac output. So remember, stroke volume times rate is cardiac output. Now there's preload and afterload. Just before the chambers of the heart contract, that's systole. So remember, the top number of the blood pressure is systolic. So before they contract, that's the systolic part, they're filled to their maximum capacity with blood. The degree to which the myocardial fibers are stretched is called preload. The more the fibers are stretched, the more forceful the contraction will be. This is called Starling's law, or the rubber band analogy. The more you pull that rubber band, the faster it's going to pull you back. If you just pull a little bit, it just has a little bit of pull. Pull that way back, wham, right? So the more blood that's pushed into the heart, you're going to stretch those muscle fibers, and then it's going to push really hard. That's preload. So you want to make sure you fill the heart. So you stretch those muscle fibers so it contracts vigorously and pumps that blood out. Afterload is the pressure in the aorta that must be overcome for the blood to be ejected from the ventricle. So we want to, what are things that would increase the pressure in the aorta? Well, constriction would increase that pressure, right? And atherosclerosis, or hardening of the arteries due to maybe fatty plaque buildup. Those will increase pressure. So the afterload is very high, and it's hard to push blood through that afterload. In heart failure, the myocardium, or the muscles in the heart, become very weak and cannot eject all the blood. So it goes like this. It doesn't eject all the blood. It can happen on the left side, the left ventricle, or the right side, right ventricle, or both. If it's left side, we call it left-sided heart failure. Right side, it's right-sided heart failure. So what happens in the two sides? In left-sided heart failure, the left part of the heart, which pumps the entire body, if it can't pump all the blood out, you lose blood pressure to the whole body. So you don't get good perfusion to the other distal organs, to the brain, to the feet, and blood starts backing up. Remember, the left ventricle is just not doing that. So blood wants to get into that left ventricle. Where does that blood come from? The blood that goes into the left ventricle comes from the lungs. If the right ventricle is pumping good, where does that blood go to? The right ventricle puts blood into the lungs. The left ventricle is weak. Right ventricle is putting blood in the heart, in the lungs. Left ventricle is not putting out blood to the body. So every time the right ventricle beats, it goes into the lungs, and some of it goes into the heart because it's not emptying completely. You start building up blood into the lungs. Eventually, fluid starts spilling into the lungs, and what will you notice? Crackles in the lungs, fluid building up in the lungs, decreased oxygenation, fatigue, choking sensation, coughing. So left-sided heart failure will result in lungs filling up with blood. So remember, this is key for nurses. If a person has a congestive heart failure and you hear crackles in the lungs, it is probably left-sided heart failure because the right side is pumping the lungs full of fluid and the left side's not letting it out. What about right-sided heart failure? Right-sided heart failure, where does that blood come from? That comes from the superior and inferior vena cava, the venous system. The left heart is pumping good. And that's pumping blood everywhere. It's going to the brain, going to the liver and the kidneys. It's going to the arms and the legs. Good stroke volume in the left side. Pumping that blood out everywhere. Right side, not pumping a lot. So the blood is backing up in that inferior and superior vena cava. Mostly in the inferior vena cava. Because veins don't pump, right? So blood starts pooling in the lower part of the body. Starting in the feet and ankles, then the calves, then the thighs. Remember, with left-sided heart failure, blood starts pooling in the lungs. Right-sided heart failure, it starts pooling in the body, in the legs. So you start seeing ankle edema, and then calf edema, and then generalized edema. You also will still feel a little more tired because if the right side of the heart is not putting blood into the lungs, then the oxygenated blood, there's less oxygenated blood pumping out of the left. So you can have the similar symptoms there, but where is the fluid building up will tell you which side of the heart is having a problem. Lungs, crackles in the lungs, left-sided failure. Edema in the legs, right-sided failure. Both will have everything. So loop diuretics. Most common is called Lasix. That's the brand name. The generic is furosemide. Lasix, here's something to remember. How long does it last in the body? How long is the effect of Lasix? It lasts 6 hours. Lasix lasts 6 hours. Learned that from a hospitalist at Holy Family recently. Quite interesting. Simple to remember that way. Use it for heart failure and high blood pressure and kidney and liver failure. It blocks the reabsorption of sodium and chloride from the loop of Henle. So it reduces edema associated with heart failure, cirrhosis, and renal failure. It can be given IV or PO. These are the most effective diuretics. Given IV or PO, IV obviously the effects happen very fast. When they give an IV, it causes the kidneys to put out a large amount of fluid in a very short time. So if a person has high risk for failure, or high risk for falls, this is a dangerous drug because they're going to need to go to the bathroom a lot, right away, with huge urgency. So the increased urine output is even when blood flow to the kidney is diminished, which makes it valuable in renal failure. Side effects are some of the obvious ones. Thirst, dry mouth, weight loss, confusion, and headache. Why would you have confusion and headache? Well, dehydration. Hypotension or low blood pressure, dizziness, and fainting. Potassium loss is the big one, though. That's dangerous. And especially if you're giving it IV, you need to know what their potassium level was that day. You need to know potassium level. And potassium is abbreviated as K+. K+. And that's the potassium ion. If you're giving furosemide with your instructor and you don't know what the potassium level is, they probably won't let you give it. Now, there's only one way around, one time that you will give potassium or furosemide if you don't know the potassium, and that's if there's no potassium level in the chart, which happens in a nursing home frequently. But in the hospital, especially giving IV furosemide, there will be a potassium level almost every day or multiple times a day. You're at risk for hyperglycemia, high blood sugar. Hyperuricemia or gout is increased by 40%. Stevens-Johnson syndrome sometimes happens. So what are some things you're going to need before giving this? Well, obviously you're going to need to check for allergies. And you want to give these in the morning, ideally, to prevent nocturnal urination. People get up in the middle of the night, they're tired, they've just been sleeping, they're going to fall. So give these in the morning whenever possible. Baseline vital signs, baseline weight, vital signs on a regular basis, weight every day. If the blood pressure drops, you're going to hold this medication. You're going to check electrolytes, especially potassium, but also sodium and chloride. You're going to monitor the BUN and blood sugars. You're going to assess for edema. Was the edema always there? And then is it improving? Check for daily weights. Monitor I&O. Make position changes slowly. These people are very, very much at risk for orthostatic hypertension, or orthostatic hypotension. In other words, blood pressure dropping quickly when you change from a laying to sitting or sitting to standing. You might be giving potassium supplements. And if you give potassium supplements, if you're giving them orally, you want to give them with food. They are big pills. Thiazide diuretics. These are the largest and most commonly prescribed class of diuretics. They're less effective than loop diuretics, especially in severe renal failure. 99% of sodium is reabsorbed. Thiazide diuretics block sodium reabsorption. Okay, let me rephrase that. Normally, 99% of sodium is reabsorbed. Thiazide diuretic blocks the sodium reabsorption and it's excreted into the urine. When sodium is excreted, water follows. So water always follows sodium. And so blood volume decreases and blood pressure drops. So a person who has sodium issues, if they have a lot of sodium, a thiazide diuretic will let sodium be pushed out of the system. Water goes with sodium because sodium always goes with water. Come on with me. Always. So you lose sodium and you lose water. This is why when you eat that bucket of popcorn at the theater and it's full of salt, sodium's in your blood, sodium goes, come on water, stay with me. Because sodium sits in your system, pulls all that water in. That's why you have that rapid weight gain overnight after that bowl of popcorn. Chlorothiazide, the side effects are the same as loop diuretics, except chlorothiazide does not cause ototoxicity, where loop diuretics can cause ototoxicity. So that's a major side effect of loop diuretics is ototoxicity, ringing in the ears. Thiazide diuretics, no ototoxicity. Potassium-sparing diuretics is the third type of diuretic. The most common one is spironolactone, or the brand name aldactone. It's commonly used with thiazides to treat high blood pressure, so that way you get all the effects of diuretics. Normally, sodium and potassium are exchanged in the distal tubule. With the sodium and potassium are exchanged in the distal tubule. Sodium is reabsorbed back into the body where potassium is excreted. That's normally. But with a potassium-sparing diuretic, the potassium is not secreted out. It's kept into the body. So some side effects here, as with all diuretics, dehydration, thirsty, dry mouth, weight loss, hypotension, orthostatic. But the big difference between loop diuretics and thiazide, which cause potassium loss, this one, you can have excess potassium or hyperkalemia. Low potassium is hypokalemia. Spironolactone creates hyperkalemia. In any case, your instructor will always ask you for every diuretic, what's the potassium level? You need to know the potassium level. Let me repeat that. You need to know the potassium level. K plus is potassium, and you need to know it. I can't reinforce that enough, because 2 drugs will drop the potassium. This one will raise the potassium. Too little or too much, both will cause devastating and deadly results. We have some questions we'll be talking about in class to discuss diuretics. 3 categories: loop, thiazide, potassium sparing. The loop and thiazide let potassium get dumped out. Potassium sparing saves potassium. The electrolytes you need to know: you must know potassium. You also need to know sodium and chloride, but potassium is number 1, followed by sodium and chloride. If you don't know that, your instructor probably won't let you pass the meds. Unless there was no lab value to check. And then say that. There is no lab value today. The most recent value was blah, 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 blah. That's how you handle diuretics. They're used for heart failure. They can be used in renal disease. They can be used for hypertension. They're a powerful drug, and they're almost always used for every person with high blood pressure, either alone or with another medication. And coming up, in the next section, we're going to be talking about 2 different kinds of medications: calcium channel blockers and the renin-angiotensin system medications. So come back for part C in this exciting lecture.